Hello, welcome to this presentation by FERNE, the Foundation for the Education and Research in Neurological Emergencies. This educational lecture is titled The Evaluation of Emergency Department Dizziness Patients, New Concepts. My name is Edward Sloan. I am currently Medical Director of the Physician Assistant Studies Program at Dominican University. I have most recently been an attending physician at Carle Foundation Hospital, and I am Professor Emeritus in the Department of Emergency Medicine at the University of Illinois at Chicago. Support for the development of this lecture was provided by EB Medicine. I am currently President and Board Chair of FERNE. The content for this lecture comes in large part by the monograph titled The Timing and Triggers Approach to the Patient with Acute Dizziness by Jonathan Edlow. It was published in Emergency Medicine Practice by EB Medicine, December 2019. Other parts of this educational lecture and the complete lecture are available at the FERNE.org website or on our YouTube FERNE.org channel. Also available is the June 2020 podcast, which was presented to participants in 46 countries, as well as a CME option on the EB Medicine website at ebmedicine.net, as well as at the specific website address noted below. Please note the disclaimer listed below. In general, this information is intended to augment and not replace the clinical judgment that guides the management of any individual patient. What about triggered episodic vestibular syndrome? Now, this is the third strata that we have, and it's again here in the red rectangle, and let's go through these. Now, triggered episodic diagnoses, what do we mean? There are specific triggers that induce symptoms. A change in head position, or standing up, or movement of the head. It normally lasts less than 1 minute. These patients can be seen to have panic attacks or anxiety disorders, but again, these are diagnoses of exclusion because they may have anxiety really because they're getting dizzy and they're worried that it could be a stroke. These patients are generally not dizzy at baseline, and what I'm talking about is if patients have baseline dizziness and it gets exacerbated or worsened, but at baseline they have some dizziness, this is more commonly seen in acute vestibular syndrome, not episodic vestibular syndrome. So, BPPV, I'll finally tell you, is benign, paroxysmal, positional, vertigo. It is peripheral. It is a benign etiology. These are very brief episodes of dizziness. There are episodes that wake the patient up from sleep or they wake up and are profoundly dizzy. The dizziness can occur with lying down or turning their head in bed. And when you get this symptom, the positive likelihood ratio is 60, which is huge, which means if they tell you that when they're lying down and they turn their head in bed or they wake up with dizziness in bed, this is likely BPPV or benign paroxysmal positional vertigo. This is most often the posterior canal, and this is the type of intermittent triggered dizziness that is diagnosed with the Dix-Hallpike test or sometime the supine head roll test. Now, a BPPV important nystagmus note. Remember, when you have these central nystagmus signs such as rotatory, vertical, or changing direction nystagmus, or unprovoked nystagmus to one side, these in AVS are considered central. But when you're considering BPPV, which is a triggered event, not acute vestibular syndrome, you can have these abnormal nystagmus findings and they are not suggestive of a central etiology. In other words, in posterior canal BPPV, the nystagmus is vertical and or rotational. In horizontal canal BPPV, the nystagmus is horizontal and direction changing with gaze, which we had said with acute vestibular syndrome is suggestive of central. In this case, it is not. These are benign findings in triggered EVS BPPV, but are worrisome in acute vestibular syndrome. So again, nystagmus interpretation depends on if the symptoms originally suggest acute vestibular syndrome or a triggered episodic vestibular syndrome, including BPPV. Now, I mentioned central paroxysmal positional vertigo. I must admit that this is a serious concern. It's the one other concern besides a posterior circulation event. The central paroxysmal positional vertigo is from a central or serous etiology. It occurs when there are structural lesions adjacent to the fourth ventricle. It can occur in the setting of tumor, MS plaque, or a small brainstem stroke. These patients often will present with headache, diplopia. They frequently recur. There's abnormal cranial nerve function or abnormal cerebellar function. There can be downbeating or non-extinguishing nystagmus. That is to say, most times when you have lateral nystagmus, it'll extinguish and lessen over several seconds. If it continues and it's severe and it does not appear to extinguish, this might suggest a central etiology of the intermittent triggered paroxysmal positional vertigo. And if you have nystagmus in isolation that's new, without dizziness, this again would suggest a central etiology. And lastly, if there's no or poor response to our positional maneuvers that are designed to improve dizziness, a central etiology should be suspected. So how do we deal with this? In the emergency department, when you only have one chance to examine a patient, if they were previously normal and now over the last several weeks to months they have several episodes of dizziness that sounds like BPPV, but it's either severe or it has these other characteristics that suggest a central etiology, a CT scan in this setting might and should be done, and an MRI should be considered, especially if when they have what are considered to be therapeutic maneuvers, there's no relief whatsoever, neuroimaging should be performed. Now, another cause of triggered intermittent vestibular syndrome that is triggered by standing up can be orthostatic hypotension. It again is peripheral. It is most often is benign, but it can be serious. You're looking for orthostatic vital signs which suggest hypovolemia. And obviously this might be optimally performed, the orthostatic vitals, after treatment, because if they're orthostatic before treatment, you're going to have to check for orthostatics after the treatment. But on the other hand, if you check for orthostatic vitals before treatment, you can say then that it's likely orthostatic in cause and prove that it resolved with treatment, which is another way to address what is a peripheral cause. You know, remember when you stand patients to check for orthostatic vital signs, they need to be standing for 2 to 3 minutes before you check for their standing orthostatics and or do sitting orthostatics in between the lying and standing orthostatics, because it takes a few minutes for the vital signs to normalize. And what are orthostatic vitals? A heart rate of increase of 20 to 30 beats per minute is by far the most reliable marker for orthostatic hypotension, but a decline in systolic blood pressure of 20 more millimeters of mercury or a decline in diastolic blood pressure greater than 10 millimeters of mercury also can be utilized to suggest orthostatic hypotension. Here are some other more rare triggered episodic vestibular syndrome diagnoses. Superior canal dehiscence, posterior tachycardia syndrome. Panic attack can cause this, but again, I would say this is a diagnosis of exclusion because people may be feeling panicked or anxious because they're having dizziness and they're worried they're having a stroke and could have the, quote, big one. Also, vertebral artery rotation or Bowhunter syndrome can be a cause of triggered episodic vestibular syndrome. In conclusion, the ATTEST system for the evaluation of the dizzy patient includes the following: A, associated symptoms, T, timing and triggers, ES, examination signs, and T, confirmatory testing. ATTEST. When evaluating an ED patient with dizziness, please consider the following. Using the ATTEST system for evaluating ED dizzy patients, those patients with acute, severe, continuous symptoms should be considered to have acute vestibular syndrome. Patients who have intermittent symptoms or non-continuous symptoms at the time of evaluation are noted to either have triggered or spontaneous episodes of dizziness and vertigo. Topping the list of diagnoses using the ATTEST system are orthostasis, BPPV or benign paroxysmal positional vertigo, and posterior stroke. BPPV can be diagnosed with the Dix-Hallpike maneuver and can be treated with the Epley maneuver either in the emergency department or in follow-up. It is noted that you should evaluate patients with caution in the setting of the COVID-19 pandemic, as the COVID virus can cause neurological symptoms and/or can complicate those neurological symptoms because of poor PO intake and dehydration, which can cause orthostasis. Electronic medical record templates and dot phrases can help to make the exam process more systematic and easily accomplished using the ATTEST system. When evaluating dizziness patients in the emergency department, the following is recommended. Understand that the dizziness pathologies using the ATTEST system fall into 3 diagnostic strata and basically involve 6 diagnoses and 3 specific treatments for those diagnoses. Also recommended is that you study the Nystagmus findings, significance, and BPPV maneuvers, Hallpike and Epley, online and in the monograph from which this lecture was obtained. Also, create EMR templates and dot phrases to exclude posterior stroke findings in your dizzy patients in the emergency department. Explain the etiology of the dizziness, including the diagnosis and treatment, and provide appropriate referral for patients with dizziness, explaining to them symptoms which should cause them to come back to the emergency department for repeat evaluation. Lastly, utilize caution when evaluating dizziness patients in the emergency department in the setting of COVID-19, as this virus has both neurological complications and symptoms and can cause orthostasis due to decreased PO intake. If you have specific questions related to this educational content, please send an email to fern.org@gmail.com. We encourage you to go to the fern.org website for more content related to this educational program and other content related to the care of patients who present to the emergency department with acute illness and injury related to neurological emergencies. Thank you for your participation in this FERNE educational program.